Welcome and thank you for joining us today for the sixth webinar in our year-long COVID Commons webinar series, Taking Back Control During COVID-19. I'm Nate Wade, your host for today, and I'm the Senior Director for Strategic Initiatives at ASU's College of Health Solutions. I co-lead our college's COVID-19 Diagnostics Commons initiative with Mara Aspinall, who will be moderating today's event. Mara is a professor of practice at ASU's College of Health Solutions and a diagnostics industry expert who helped found our master's degree in biomedical diagnostics. She is also an advisor to the Rockefeller Foundation on testing and reopening schools, and there was a recent announcement last night on the K-12 National Testing Action Plan. Mara and I would first like to recognize and thank the Rockefeller Foundation for their generous support of our COVID Commons initiatives. We would also like to thank our partners at the World Economic Forum who have been instrumental in helping us with all aspects of our Workplace Commons initiatives. Before introducing our panelists, a few housekeeping items. First, this session is being recorded and it will be posted on our website, asucovidcommons.com. Next, we will have a discussion and Q&A session during the last half of this webinar. Please submit your questions using the Q&A feature. We value your feedback and plan to send a brief survey asking for your input about today's webinar and ideas for future event topics. Finally, we encourage you to get involved in our COVID Commons community by visiting asucovidcommons.com. Now that housekeeping is behind us, I'll turn it over to Mara to introduce our speakers. Mara? You're on mute.
You'd think I would have learned that by now. Good morning, everyone. Good afternoon. Thank you, Nate. And welcome to today's webinar, Global Perspectives on COVID-19 Variants, Vaccines, and Testing. When we look at the world today, we see three factors at play. And I will say some positive, some negative. Positive, vaccines are available in many countries. The US reached 3 million vaccines in one day, and that pace continues across the country. Not the same in every state, but still strong. Negative, like every virus, SARS-CoV-2 is mutating, and we now have several variants of concern that may evade those vaccines. Positive, the vaccines are not just available in a few countries, but many, and we'll hear about that later today. In particular, some of the countries, including Israel, that have done a phenomenal job in getting it out to their population broadly very quickly. But what's the positive and negative? I would talk about testing demand. COVID testing demand is way down, more than 40% down from the high at the end of December and beginning of January. The good news about that is that fewer people are getting sick, and symptomatic testing being down is great news. The bad news is many believe there's no longer any need to test and have significant, what I'd call testing fatigue. So what we need to do today is talk about our favorite question: how do we take back control? But in something unique from this webinar we haven't done in the past, I'm going to share just a couple of slides before I introduce our panelists, and we're going to start with Alan Tenenbaum. To make sure that we're all on the same page in terms of the basics, let me share just 3 slides. First, everybody pretty much knows the picture of our unfavorite virus. Where have we come? Well, if we look at the history of testing and how this relates to the variants that we'll be discussing today, I think it's very interesting to start with the idea, where did it start? It started with symptomatic diagnostics, lung CT and bronchial lavage for this new disease that nobody understood. We then moved to active disease diagnosis, initially PCR and then viral antigens. Next, we moved to screening, and much of the same technology, but used in slightly different ways, individual or pooled PCR, as well as rapid antigens. But importantly, where are we going? And what I believe is that where we're going from here is all about, I hope, community surveillance, outbreak surveillance. It's not going to be about active disease testing. It's going to be looking for breakout and outbreaks. So what are the technologies from a diagnostic point of view at that point? Well, number one is wastewater. That's primarily done in PCR and NGS. Number two, biohazard air monitoring. You've seen a couple of companies, including Thermo Fisher, that came out with one just last week to talk about how they could monitor the air in a conference facility, in a church or otherwise, to detect COVID-19 broadly. Speaking of air, the next area is breath tests. And these breath tests exist today, but their sensitivity, i.e. their false negative rate, has been sufficiently high that none of these have been approved essentially in any developed country around the world. There is an interesting test, some of you may have seen it. It's called the Scream Box. It's really a breath test, but very clever. You walk into a box and you scream or sing, but basically you expel air, and they then test that air for COVID-19. I can only imagine how tough it is to then wash the box before somebody else comes in, but it sounds like a game show. Next is scratch and sniff tests. And many of you are probably aware that more than 50% of people who are symptomatic, or actually even not symptomatic for COVID-19, have a new loss of smell. So these very simple tests might be useful in environments where people need to be tested very, very quickly. And what they do is they give you a strip, you scratch them, and you have to say what you smell. So it's not like they just give you coffee and say, can you smell it, yes or no? A little bit more sophisticated than that. University of Colorado has already published on that. And lastly, COVID sniffing dogs. While there's probably some smiles in the audience about this, dogs have been used very aggressively for drugs, for smuggling. And right now in the Northern European airports, these are used for incoming passengers to look to see if they smell of COVID-19. And they have been highly effective. I will have with a co-author, Jeannie Francis, a T3 blog on this next week and the accuracy of these COVID sniffing dogs. So if we take that and we say, these are the technologies, where are they being used? And I think this is where this is unique from any other, even epidemic we've had. It started in hospitals. It's moved to central labs, public health, national, regional, university, then moved to point of care. And what I see in the future is this is going to move aggressively to home and self-tests. And that will be rapid antigen, as well as molecular and LAMP and PCR. If you go to testingcommons.com, you could see all the tests that have been authorized. But then lastly, let's talk about today. We've had a lot of questions about what is the difference between a mutation, a strain, a variant. And what I tried to do in this simple cartoon is start with the fact that all viruses mutate. They might have a single letter change, but it's basically coding the same protein. So there's not a fundamental change in the virus itself. But then more mutations occur, and potentially a new variant is born, and they need to be relevant. So what I suggest here is there are three different types of variants. One is variant of note. It doesn't seem to affect infectivity, virulence, severity, mortality, everything works. Number two is a variant of interest that seems to be growing. And number three is variant of concern. And that's where we are now with several variants. And just this morning, the FDA said that one of the monoclonal antibody treatments from Lilly can no longer be sold in the US because it does not work against variants of concern. When there is a consensus that the variant is relevant, it's considered a new strain. Right now, people will use these interchangeably, UK variant, South African variant, Brazilian variant, but some of them may become a separate strain. So I hope that helps put us all on the same page. Alan will talk and will give you a much better explanation and how these have affected the work that he is doing through the World Economic Forum, but more on that in a moment. So with that basis, I'm very pleased to introduce Alan Tenenbaum. Alan is trained as an infectious disease physician. He brings 25 years of experience in the pharmaceutical industry, clinical medicine, public health, and academia to his position as Chief Medical Officer, Global Public Health at Johnson & Johnson. In this role, he is responsible for building strategic relationships with key stakeholders and partners in government, multilateral institutions, non-governmental organizations, NGOs, and again, academia, and around the world. He is not focused in one area, but truly global. He is a leading figure in facilitating private sector engagement to advance the global health security agenda, and he is founder and co-chair of the Private Sector Roundtable. This is a coalition of companies dedicated to bringing private sector capabilities to global health. Today, in his position, he will be speaking as the Platform Fellow for Health and Healthcare at the World Economic Forum. During this 18-month appointment, he will drive forward critical initiatives on pandemic response and preparedness, helping to shape the post-COVID global public health architecture. Alan Tenenbaum, is based in Israel, and he will give us his unique perspective, and we'll have the chance to have a Q&A with him before we move on. Over to you, Alan.
Thank you very much. It's a pleasure to be here, and thank you for inviting me to be a part of this panel today. Good morning to all of you. It's evening here, and really happy to be a part of this. As Mara said, most of my work is focused on partnerships, on public-private partnerships around health security and around pandemic preparedness. And right now I'm working as a fellow at the World Economic Forum on secondment from Johnson & Johnson, helping to build out some of those partnerships to help us to exit from the current pandemic crisis and also hopefully to help us become more prepared in the future. One of those partnerships is in fact around surveillance for variants, and perhaps if there's an opportunity during the Q&A, I'll be able to speak a little bit more on that, and my co-panelists are also involved in very similar efforts. But I've been asked to direct my opening comments towards the vaccine rollout here where I live in Israel. I've lived here for 5 years, and I've had an opportunity to experience the healthcare system here, first off as a consumer, but also through the entire period of the pandemic response, the early response pre-vaccine, and then also the rollout of the vaccine over the last number of weeks, although it feels longer than that. Just to level set for a moment, a little bit about the country. The population is approximately 9.3 million people. And for context, that's a bit more than the population of the state of New Jersey. And when you look at the square mileage of Israel compared to New Jersey, it's pretty much the same. So approximately the same size and roughly the same population, but obviously very, very different. Every citizen in Israel has access to high quality healthcare through a national health system. And that system is organized into 4 health maintenance organizations. In Hebrew, they're called Kupot Cholim, which translates directly to sick funds. But I prefer to call them health maintenance organizations. I think it's a better name. Care is accessible at no cost or at very low cost to everyone, every citizen. You can access care privately if you prefer. If you want to see a particular doctor, if you want to move yourself a little bit more quickly through the system, because it is a national system, there's heavy government involvement, it's high quality, and we've been very satisfied with our access to care and the quality of care here. But sometimes, if you want to get an MRI and it's not an emergency, but it's urgent to you, you may want to find your way elsewhere in the system and go privately in order to expedite the process. But even then, the price that you would pay, the cost, is marginal compared to what you would pay out of pocket for an MRI in the United States. What's unique about the system really is that all medical information on every single person is captured and stored in an electronic health record. And that record goes back for decades on individuals through the system. So that makes it ripe for studies, for looking at real world evidence and looking at how new treatments or interventions are rolled out. So how did Israel do over the last year? Well, there have been about 830,000 cases of COVID identified. testing here is easy and free to access. The numbers of tests have gone down dramatically here lately, but perhaps for slightly different reasons than they have in the United States. We've had, at last count, I believe these numbers from yesterday, 6,130 tragic deaths, which works out to 700 deaths per million population. So not the worst and not the best, kind of right in the middle. And there's, as everywhere, a political element to this. If you love our prime minister, then you point to Belgium, which has a population of 11.5 million and has had 2,000 deaths per million population. And you talk about what a great job we did here in Israel. And if you don't like the prime minister or the government, you look at Cyprus, which is a very close neighbor, much smaller population, 1.2 million, but they've had 280 deaths per million population. So there's a political element here, just as there is everywhere else. The vaccine rollout. The first shot of vaccine, of COVID-19 vaccine, was administered on December 19th to the prime minister. Then they started to roll it out to the population, starting with people over the age of 60, frontline healthcare workers, and people at high risk due to comorbid illnesses. And the campaign picked up speed very rapidly, approaching 200,000 vaccines administered a day. And now compare that to the number Mara used for the United States, hitting 3 million a day. You could immunize a third of the population of Israel in one day if you were able to execute at that speed. But 200,000 a day for a population of 9.2 million is actually quite fast. And there was ample supply. As of today, about 5.2 million people have received at least one dose. That's 57% of the population. 4.7 million have received both doses. We just crossed, so then the 50% mark for people who've received both doses of the vaccine that's available here in the country. About 93% of the age 70 to 79 age group have already been vaccinated with 2 doses, and an additional 4% on top of that with 1 dose. So 97% of the population 70 to 79 age have already received at least 1 shot, and most 2. And if you look at the younger population, age 20 to 29, about 60% have already received both doses, and 12% on top of that have received 1. So 72% have been exposed to a vaccine in the 20 to 29 age group, so, which is pretty remarkable coverage at this point. As of March 14th, about 100,000 people didn't show up for the second dose. And there are a lot of reasons for that that I just don't have the time to get into right now. So it was a quick and efficient rollout. When Pfizer issued a press release, and we use the Pfizer vaccine in Israel, and for reasons that you'll know in a moment if you don't know already, when they issued their press release on November 9th, there was no deal to acquire the Pfizer vaccine and bring it to Israel. There was no signed deal. The government, though, stepped in, and you could argue that this was innovative, or you could argue that they were kind of pushing their way to the front of the line. But at the end of the day, they leveraged that electronic health record that I mentioned a moment ago that has data on every citizen, sometimes going back decades. And they offered those data up to Pfizer to answer key questions: real-world efficacy, real-world safety, and also the prevention of symptomatic and also, very importantly, asymptomatic acquisition and transmission of COVID-19. The rollout was sped up by centralized distribution and centralized allocation, centralized delivery to major centers and cities and towns. Stadiums and arenas were set up as vaccine administration centers. And most importantly, that electronic medical record and electronic access to the health system means that every citizen has an app on their phone that connects them to their medical record and their medical data and to the medical systems appointmenting system. So in essence, you go online, you press the button that you want to get a COVID-19 vaccine. It immediately knows if you're eligible based on your age or your health status. If you're not eligible, it kicks you out of the system and tells you to come back later, though you can call an appeal. But if you are eligible, you get in and you make an appointment, and you can make those appointments anywhere in the country at any vaccine center. So for myself, I could have waited a week and gotten it down the street in Jerusalem, or gotten it later that day if I was willing to drive an hour to another city. And when I left after getting that first shot, I had a little signal on my phone, a notification, and it informed me of when my follow-up shot would be. So an efficient system linked electronically all the way up and down the chain. And of course, it was free.
Yeah. Alan, it is so impressive to hear about that rollout. And we've obviously, in small pockets, it's worked well in the US as well. How do you, and we're going to then get to the other panelists, but before we go on, to ask you, how scalable do you think that is? Scalable in Israel with a very centralized system. If you have to do it again for boosters, do you see it working a second time? Or do you see that scaling to other countries?
As far as boosters in Israel, I have no doubt that they would be able to execute even more efficiently the second time around. There was a learning curve. There was some vaccine wastage at the beginning when if someone didn't show up and they didn't have a backup mechanism in place to bring someone else into the clinic. There was a story in the press of a nurse running down the street and flagging down a pizza delivery guy and bringing him in to get the last shot that was left at the end of the day. So there was some flexibility that was allowed. You would not get prosecuted here for doing that. And I know that there were some cases of physicians who were well-intended, maybe getting into some trouble in other places. Now, Scalable in other locations, this is not something that we put into place for COVID. This has been in place for a long time, and the technologies have evolved as they become available. So I think my advice would be, my hope would be, is that locations that are still rolling out their vaccines or getting ready to roll out vaccines, look around for best practices and identify where there may be initiatives that can be brought on board. I don't know whether it's realistic to put an entirely electronic appointmenting system and health record in place just for COVID if you don't have one already.
That is a challenge.
Scores the value and why these interoperable electronic health records and the ability to access your information remotely wherever you are at any health provider is absolutely critical. And that's one of the things that made it so effective here.
Thank you so much. And I just want to say for the record, in a number of ways, pizza delivery people are essential workers after healthcare. So I'm not putting out a political statement there, but they do interact with a lot of people. True. So let's now go to our second speaker, Tamsin Berry. Tamsin comes to us with extensive experience in government and public policy. As part of the COVID-19 response, she led the work in the UK to set up prevalence studies and serological surveillance. She was the former director of the UK government's Office for Life Sciences, where she worked with Sir John Bell to write their life sciences industrial strategy. During a successful career as a senior civil servant, she held a number of leadership roles in government, spanning policy, corporate communications, and that included her roles in the Cabinet Office, the Department of Health and Public Health, England. She began her career at Accenture. She studied law at Nottingham, holds a master's in philosophy, really a polymath, from the University of Leeds, and was a science and policy fellow at University of Cambridge. And Tamsin recently took all of her governing experience and launched a new partnership venture in the UK and the US, specializing in focusing and advising on population health. So Tamsin, welcome. It's great to have you here. And if you could talk about the UK rollout and how the UK is dealing with, what do I call it, the eponymous variant.
Yes, of course. Thank you so much for having me. It's a real delight to be here. I think a lot of what Alan just shared is the experience we're having right now in the UK. I don't think our rollout is quite as fast or as has been as at quite the same scale yet as Israel, but we're definitely trying to catch up. We've had 40% of the UK population receive its first dose. It's been an absolutely extraordinary effort. We've had football stadiums, libraries, ice rinks, all turned into vaccination centres working round the clock. And it looks like the single shot policy, which has really started to pay off. We're seeing real world data coming through from Scotland and England to show reduction in severe hospitalizations and death. So another great thing that I've observed in the UK is our sequencing capabilities. We have sequenced coming close to 400,000 viruses now through the COVID Genomics Consortium. And that has really helped us get a handle on these new variants that have come out and do the structural biology and the clinical characterization that is necessary to think about new policy efforts to combat the pandemic. We've also seen some other rather savvy policy maneuvers as well, building new capabilities for vaccine manufacturer and fill and finish in the UK. So really now I feel over in the UK, we're sort of asking ourselves the question on how we get to the wider end goal and open up all economies, vaccinate the world. How do we put in place systems to suppress new variants, open up the borders, and save lives across the world? And it's difficult. I'm sure. I think my personal opinion is that this is a pretty hard situation. So we don't want to make it harder with unnecessary politics. And I'm glad to see that some of the politics is resolving itself. Hoarding supplies and breaking supply chains makes it harder. Certainly poor communications, in my experience, makes this quite tough. It's a very complicated subject, and we need to all do our best to explain the situation very simply. And I'm just glad to see lots of movements in these areas now working itself out. And I think my last reflection on what we are doing in the UK and beyond is that we're looking at the role of vaccines, but we're also looking at alternative treatments now and thinking about the role that antivirals and other biologics can play to help us combat this pandemic and future ones.
Super, thank you, and really appreciate your perspective on that. And as you may have noted this morning, the US FDA made a statement on the Lilly antibody treatment in terms of how it works against variants, and therefore pulled it from the market. So a good example of the importance of treatment. But let me ask you a brief question before we head over to Rick Bright. You've had so much experience with policy. How do you translate, particularly in the midst of this, these incredibly complex scientific pieces of information to policymakers? And many of them are not coming into this as epidemiologists. I would say 99.9% of them are not scientists or epidemiologists. How do you translate these complex issues to people who need to understand them without dumbing them down too much so they can still make the right decision? How do you balance?
Yeah, well, I mean, it's tough, as you say, and I think it helps that I don't have a science degree. I have a law and philosophy degrees, and so I always sort of need to be able to understand it myself in order to be able to communicate it to people. I think the key word that you use there is translation. Because you find yourself overwhelmed with a huge amount of data, but actually there are still massive holes in a lot of that data, and it's not complete to quite make the judgment call that you want to. So it's really important to sort of filter that noise and be really crisp on what the exam question is that you're trying to answer. I think if I look at some of the task forces in the UK, the vaccine task force was extraordinarily good at setting its exam question and then delivering on the objectives. I think you've got to be quite comfortable with taking decisions and managing risks, communicating them, as I just said, in a sort of simple but easy way. But then, when you get it wrong or you make a mistake or you realize that data is incomplete, you sort of need to flag that as an issue. And I had personal experience of that working on antibody tests, rapidly trying to develop antibody tests for the UK, but then not entirely being sure what the right use case was for them at the same time. And so we actually ended up with the test, but we still needed to answer the immunity question, whether or not you could get COVID twice, whether or not it mattered, whether or not you had antibodies in your blood. And I think being able to recognize where the gaps are is really important as well.
Yeah, thank you. And I know even the subtleties there, antibodies versus neutralizing antibodies, so lots to discuss. So let me introduce our third speaker, and then we'll open it up to Q&A. Our third speaker is Rick Bright, and I'm particularly excited to introduce Rick, as Rick has recently joined the Rockefeller Foundation as Senior Vice President of Pandemic Prevention and Response. He leads the development of the Foundation's Pandemic Data and Action Platform, which, as we just talked about, it's all about data and transparency and clarity of that data. Most recently, Rick served the U.S. Department of Health and Human Services as the Deputy Assistant Secretary for Preparedness and Response and the Director of the esteemed Biomedical Advanced Research and Development Authority, better known as BARDA. He has served as key advisor in so many important roles, including the development of the Coalition for Epidemic Preparedness Innovations, the WHO Research and Development Blueprint for Action to Prevent Pandemics, the WHO Global Action Plan on Influenza, and the National Academies of Science, Engineering, and Medicine Forum on Microbial Threats. Tamsin and Alan have worked with Rick before, and I can just say there are a few others who can give us as broad and deep a perspective as Rick will do today. So Rick, over to you. Please give us a sense of what the US is doing today, and to the extent that you can share it, what the plans are from Rockefeller and more globally in the future around vaccines, variants, and testing. You're on mute.
There we go. Mara, thank you so much for including me today with this great panel and great audience. There's so much we can talk about, as you've already said, and as you already heard from both Alan and Tamsin. Yes, there's a lot to unpack. I'd like to say how excited I am to be at the Rockefeller Foundation, especially in this moment in time during this outbreak. The Rockefeller Foundation, as we all know very well now, has been working very hard to improve access to the tools that we need to fight this pandemic. They've been active in testing and contact tracing and in this vaccine deployment by working with different partners in the country and around the world to increase that effectiveness and efficiency by which we deploy those tools and make sure that they're available to keep communities open and safe. In the United States, we've been really focused on getting kids back to school. And we published some really compelling reports on what it would take to support a national testing program, to support kids returning to school, to reopening our schools, reopening society, and getting people back to work and getting this pandemic behind us. And that took a lot of work. Mara, your team and others had put together and led many discussions and dialogues at all levels to come up with a strategic plan. And I'd also like to call attention that just today, I believe the report was released where they called it the National Testing Strategy, or NTAP, National Testing Action Program, where Mara and her group, actually with the Rockefeller Foundation, formed a partnership of 21 different leading testing labs and manufacturers with a goal of rapidly scaling up an ability to test and be able to support a K through 12 testing program to make sure that the environment in the schools is safe and everyone feels safe, and we're testing so we can take responsible behaviors to reduce transmission if it were to occur or emerge in the school system. And the teachers and the staff and the students all have a very safe place to come back together for in-person learning. We've also done a lot, as you can imagine, in trying to track the emergence and spread of the virus, but also these variants, as we've already discussed briefly. The United States and the world have been flying blindly in trying to understand where this virus is going, how SARS-CoV-2 is changing, and what is the impact of those changes, those mutations leading to those variants of concern. The Rockefeller Foundation hosted a convening in the United States just to look at the various challenges that we have in front of us to not only rapidly identify a new variant, but also to characterize that variant and to share the information that we've learned from those variants so public health officials and government officials can make the right decisions as quickly as possible to change the course perhaps, or to double down on countermeasures and non-pharmaceutical interventions, wearing your mask, social distancing, restricting travel, while we get a handle on those variants and get in front of them once again. They can also be very, very important in helping to guide manufacturers and how they might change their vaccine formulation or therapeutic formulation. And we're finding in those discussions, and we released some reports a couple of weeks ago on a national strategy to improve genomic surveillance, to being able to detect and identify those variants of concern. But we're learning this isn't just a problem in the United States, Mara. This is a problem around the world. Many countries don't have the capacity or capability to sequence or to understand how these viruses are spreading in their country. And many countries get the information at very different times. So there's a lack of equity, a lack of transparency, and a real big challenge in sharing those data in real time. So the Rockefeller Foundation, as a part of the group that I brought on board to help lead, is building towards a new pandemic prevention institute, a system that will coordinate rapid detection of novel emerging pathogens from anywhere around the world and be able to rapidly characterize those pathogens to understand the risk that we face in human health or economic health or whatever risk might be in the pathway of that newly emerging pathogen or virus or variant of an existing virus that we know. Our vision is to make sure that we not only have that information quickly, but we can translate it into very easy to understand reports and assessments and share those equitably, again, across the globe for rapid response at the government level, the public health level, and even the individual level. Imagine what you could do as an individual even if you knew the risk of a variant or a newly emerging virus in your community. You were waiting on the government or public health officials to alert you and provide guidance, but you actually had the power at the same time to make your own risk assessment and to not go outside or to wear your mask or social distance or get treated sooner. Our vision is once we have this multi-variant, multi-dimensional data where we can make it really easy to review and share assessment, it will empower individuals and governments so we can never again have a pandemic on our hands and we can stop one from emerging within the first 100 days. I'll stop there. There's so much going on, but thanks, Mara.
No, thank you. And you brought up so many key points, and the topic of this whole webinar series is taking back control. So it doesn't matter what your politics are, you want to be in control of your own life. So I think that that's a perfect place, to both to end the overview and start the discussion. So let me talk about that and ask you another question. When you talk about the initiative, the genomic initiative, and making sure it's around the world, I think it's fair to say the one thing we've learned here is the world is a small place. So even if we want to close borders, it just somehow doesn't work. And even in the deepest and darkest part of the pandemic, there were still planes flying. So how do we, again, we'll come back to balance, and I'll start with you, Rick. How do we balance the relationships and partnerships around the world to share information without a xenophobic approach that says it's ours? And how do you ensure that everybody's a part of it? Because, if you only have half the countries of the world, can we really be effective in understanding, as you said, what's happening?
Well, I think it goes back to the basic principle, Mara. It's very important to recognize that we are all in this crisis together. A pandemic, by definition, is global. And until we stop the pandemic everywhere, then it's not really stopped anywhere. Now, in this COVID-19 pandemic, we have seen different countries respond very differently for a variety of reasons. One of those reasons, I believe, is that we don't all use the same tools. We don't have access to the same information at the same time. So we've seen major gaps in how much information is available to different governments and information that isn't translated from the governments down to individuals. I believe one way to try to balance that and to improve this and close this gap is to establish a trusted platform, a platform that's built on global public good, not sovereignty of a sample, not profitability of a medical countermeasure that not all countries have access to at the same time, but built on the principle of global public good that can help us standardize a variety of different data types for consistent and rapid dissemination and globally at one time. We want to establish then sort of a neutral foundation for the data and information sharing, simplify it to the degree that is empowering to policymakers and public health officials, not something that seems for special entitlement that is only available for a few who can afford it or a few who have the tools to analyze it. We want to be able to give everyone the same information at the same time so they can determine their local risk or regional risk and respond locally and regionally. At the same time, the rest of the world can be on guard to offer assistance and better prepare the forces to contain that virus so it doesn't spread globally.
And has this, and I'll open it up to everybody, has this ever happened before on a global scale? And do we have some experiences to call from in the past that on a health perspective, we've had global cooperation?
Well, I'll give one simple answer, and I'm sure the others have some comments too, but influenza is something we track every year. You know, the emerging threat of influenza is an annual seasonal disease, and it kills about 600,000 people around the world every single year. And so tracking and sharing the emergence of different seasonal influenza viruses is critical to formulating the vaccine twice a year for Northern and Southern Hemisphere and making sure that that same composition is available when that season hits in those parts of the world. And then very importantly, a nice global collaboration is in place through WHO, through the GISRIS system, to track novel emerging influenza viruses that have the potential to cause a human pandemic. So usually these are viruses that will jump from a bird into a human directly, or maybe they've been mutating and recombining as influenza viruses do, reassorting, and something novel has emerged. We are now able to detect that very quickly. We saw just 2 days ago, a person died from H5N6 influenza virus. And the world knew about that really, really quickly, so we can immediately assess to see how we can respond to that and if it's a bigger problem. So I think that's one good example of how we work together.
Yeah, and that is terrific and makes me feel much more comfortable. Alan, do you have, what is your experience here?
So I think Rick really did put his finger on that prime example of how we collaborate globally every year, in fact, not only to detect the predominant strains of influenzas, but then collaborate public and private to provide that information to vaccine manufacturers so that the right flu vaccine can be manufactured and mass produced for the following season. And I think that one thing that we've seen also coming out of the COVID-19 response, but also even going back to the Ebola response, to the Ebola outbreak in West Africa a few years back, the level of collaboration between public institutions, governments, and the vaccine developers and manufacturers has just gotten better and stronger every step of the way. And because of that collaboration, we were already working together to make sure that there were the right investments, the right seed money, the right catalytic funding in place, so that new technologies and platforms were already being developed that could be rapidly pivoted towards COVID-19, so that once the sequence was available, vaccine candidates could be rapidly produced and brought into clinical trials. Now, you mentioned earlier the CEPI organization and how Rick was a part of founding that. And CEPI has now set its sights on a new target, and that target is 100 days from the availability of a sequence to the submission of data for an emergency use authorization. That is incredibly aspirational, but achievable. And I think that we saw this time around, I think it was around 400 days or 420 days to get there. And if we set our mind to it and we keep upgrading and improving the degree of collaboration that exists across all sectors, then there's no reason why not in the future we can achieve that 100-day target and bring vaccines forward even more quickly and avoid morbidity, mortality, and just tremendous economic disruption all over the world.
So let me start with some questions from the audience. And then, so to the audience, please put your questions in Q&A. But I'll start with the first one, a bit of a shift. If you had to do it all over again, is the age-based vaccine distribution the right way to go? Have you been satisfied with that? Is that the way you would design a new system today? Anyone can open on that. I'll ask you, Tamsin.
Okay. I'm just thinking, can I respond to say whether or not I'm satisfied? I suppose what I'm thinking is that what I think has been a very common sense and right decision is to take a look at the groups who are most likely to have severe disease and hospitalization and prioritize those groups. So I don't think it's necessarily driven by age, although obviously age is a factor in for COVID-19, but to really take that prioritization approach, both domestically and globally, I think is the right one.
I see some nods, Rick and Alan. Do you agree? Anything else to add?
I agree. So when we think about the rollout, the prioritization by age, I think that really mirrored what we learned in the early days of this outbreak, that the older people were more vulnerable to this virus, older, much more susceptible to this virus. If it were to be perhaps influenza, we might still look at the age. It might appear to be another age tiering, but it almost might be the opposite, or it might be bimodal, where we had the very old and the very young that we wanted to protect first. So the principle, I think, is identifying early in an outbreak who are the most vulnerable and who are the most likely to spread and transmit the disease the most, and prioritize them with the medical countermeasure rollout, be it therapeutics if there are limits of supply, and vaccines when there are limits of supply. But also, as we've seen, to very rapidly, as supply increases, and we're seeing more vaccines produced now, to very rapidly open those tiers, so we're not holding back any groups or age groups or populations from getting vaccinated just because we're solely focusing on getting people in a certain tier or age group first. And now it's really remarkable to see the number of vaccines coming on board now, that seeing that many states, and I think that President Biden has said by May 1st to open the tiers for everyone in America to be vaccinated when they can get a vaccine.
So
Well,
that's obviously.
Can I
Oh,
jump in
Alan?
on that, Mara?
Sorry.
I just like to say that although I agree with the prioritization, I'm incredibly dissatisfied. And that's with the global manufacturing capacity for vaccines, our ability to produce rapidly, and our ability to produce all over the world, so that vaccines are available quickly in all the places that they are needed, with less reliance on fragile and politically influenced supply chains. So though as Rick pointed out, that prioritization was necessary because of supply limitations. And what I have to ask as someone who comes from the industry is, can we plan better the next time around? And there will be a next time around, so that there is warm and ready supply and manufacturing capacity worldwide, so that we don't have to be prioritizing in this way and leaving so many countries and so many people behind.
I thank you, Alan. I think that's a critical point. And so let me add a question on that in terms of the next time around. If understanding what we do now about variants and the vaccines and their various coverage, from 49%, for the new variants, how do all of you think about a booster, or a new vaccine, or the fact that this will indeed become like the flu, that we're going to have a COVID-19 shot every year, every 2 years? Are you willing to put on your crystal ball and say the likelihood of that happening?
Shall I go first?
Yeah,
I'm going to
so you take it first.
There's the brave one here, so jump on in there.
Yeah.
It's an impossible prediction to make, but I think reading the tea leaves, I would suggest that is a distinct possibility. And whilst the vaccine coverage at the moment is, I'm rather optimistic about the data that's coming through on the vaccine coverage at the moment on the new variants. I think it is a distinct possibility. And I think what's really important as a policymaker would be to think about planning for that now, building that surge capacity and manufacturing, as Alan said, putting in place those distribution and logistics systems that we know are needed, the electronic records. All of that we are building now can be the legacy for a much more future, a more efficient rollout and deployment as we have boosters, or indeed we face another pandemic.
Thank you for that, Rick. Alan, anything to add?
You know, I think that we're still learning a lot as we go. We're learning a lot about the virus and how much it can change and will change and how rapidly it will change. We're also still learning a lot about the power of the vaccines that we have and how much immunity they can provide and the duration of that immunity. One of the promising things that I've seen so far in the data that we have is that they still are very effective at preventing hospitalization and deaths, even in the face of these variants where they've been tested in Brazil and in South Africa and other places with a high prevalence of these variants. Yes, we can notice a small drop in some cases of the efficacy of a person getting infected, but what's really remarkable is they're hitting that goal of making sure that people are staying out of the hospital and not dying. And if we continue to see that, then I don't know if we would need to rush to change a vaccine formulation just because of variants emerging. We want to follow that very closely. I think the next data set we'll look for is the long-term durability of those vaccines, and not just as measured by the antibody response. So we really want to understand the other type of immunity, cellular immunity, et cetera, that these vaccines are eliciting, because that is going to give us the fuller picture on how much we need to chase the virus. And one other aspect of it is the sooner we vaccinate the world, the sooner and more powerful our vaccines that we have will be, because we need to block out all of that space for the virus to go to continue to replicate and mutate and new variants to emerge. So we are really in a race against the vaccine and the variants, but that's a global picture, not just in the United States. So we can block out that evolutionary pathway.
So let me take it from there, and I'm going to go to Alan first, particularly because of what you've seen in Israel. It was a great question that said from our audience, do you envision a near-term or long-term future where we can adopt an attitude towards COVID health policy, as we have with flu and other infectious diseases, where it's about personal responsibility to get a vaccine, not government control and government policy? Clearly, where we've been in a pandemic has changed things. Do you think that COVID will shift here, and how will this affect future pandemics?
So to that point around personal responsibility versus, say, government responsibility, I could say even here in Israel, the vaccine is not mandatory. You still have that personal responsibility to decline and not to take the vaccine. Where the disconnect then takes place is your access to social engagements, sporting events, cultural venues, and the like curtailed in some way because you've declined and you've exercised that personal right not to take a vaccine at this point in time. So, I don't think we're that far away, if I'm understanding the question correctly, from the way that we approach it from influenza. There's a sense of urgency right now. I think around influenza year to year, there's kind of a sense of complacency where you have people feeling that it's not urgent, that the risk is low. I, as a practicing infectious disease physician for a number of years before entering the pharmaceutical industry, it was, unusual to see a relatively healthy person or even older people dying in the hospital of influenza. But I can't tell you how many people call me every day to talk to me about friends, relatives, family who were sick in the hospital and dying of COVID. I know 10 people who've lost parents, one or two parents. So we're talking about something very different right now. I hope there is never complacency around COVID as there is around influenza, and that people understand why vaccines are so important to keep them safe and to keep them healthy. And hopefully that will drive uptake of the vaccine.
So our last question, because this went by incredibly quickly. Question everyone's asking: are we going to have vaccine passports? Should we have vaccine passports? And how do we get back to airplanes, long haul cruise lines, concerts, bars? Well, maybe some have already gone back to the bars, but how do we go back broadly and safely? I'm going to ask each of you to weigh in briefly. Should we have and will we have vaccine passports? Tamsin, you were brave before.
I already have a vaccine passport. That's issued right now by the Israeli government. It is a vaccine passport, and it's been incredibly controversial. And some of it is with within the country itself, and then whether or not that passport is recognized in other parts of the world. I think we have to figure out a way to be fair and equitable around this. The idea here is for everyone to be safe and to everyone to be able to return to normal life in a healthy way where we're not afraid or worried. That to me is primary. If we can do that without excluding one or another population, to me, that would be the ideal solution. I just don't think we're quite there yet.
Tamsin, and then Rick for the last word on this.
Well, yeah, I think it is obviously really important not to exclude people through a policy of vaccine passports. I did notice, however, that our Prime Minister suggested it would be your route back to the pub. So I suspect we'll see many Brits volunteering to hold a vaccine passport if it means that they can go back to the pub. On a more serious note, I do recall when I went traveling in many moons ago, I had to get my yellow fever to enter certain countries. And that didn't seem like a difficult or something that I felt like something I was taking personal responsibility. I wanted to visit that country. I was willing to go and get my yellow fever jab. If we can strike the balance right, I think a policy of vaccines passports could be a helpful thing.
And Rick, close us out here.
Great comments already. So to add to those, I think the difference I look at these, I mean, it's highly controversial area, as Alan mentioned. There's some ethical challenges as well. It depends on, I think, how they're used equitably. Are they used for travel to go from country to country, and that's a way of recognition and potential containment of a virus, reduction of transmission? Or are they mandatory and used in everyday life to go into a store, a restaurant, a movie theater, a pub, whatever it might be? And not everyone has access to the vaccines. Not every vaccine takes in each person, works effectively, et cetera. So you're still at some level of risk. And it's important to not have a passport or a tool such as a vaccine passport substitute for the awareness and the approach that you take to a rapidly spreading virus in the community. It doesn't protect you in any way. It does signal to others that you have a layer of protection. But I think it's really important to think comprehensively and how it will be used, and make sure that if it is used to exclude or bar or tighter or measure entrance, that it has an equitable use, that everyone can access it and it's used fairly.
Super, thank you. Wow, this is a great discussion. Over to Nate to close us out.
Thank you, Mara. All right, that's all we have time for today. Thank you for attending, and we hope you enjoyed the conversation and took away some new ideas. The webinar recording will be sent in a post-event email and will be placed under the webinar tab of our COVID Commons website. In the post-event email, you will also receive a survey asking for your input about today's webinar, and we thank you for your participation. We encourage you to visit asucovidcommons.com to take our Workplace Commons Keeping Workers Well employer survey. It's only available until March 31st, so with less than a week away, please go in and complete it today. Lastly, save the date for our next webinar on Thursday, April 29th at 9 a.m. Pacific, noon Eastern, where we will discuss employer and employee responses to the pandemic with experts from the Society for Human Resource Management and the National Safety Council. During April's webinar, we will also plan to share phase 2 survey results from our Workplace Commons employer survey. Once again, thank you for joining us today. Take care and be safe.
Thanks, everybody.